So, on to a next topic. Lots of crossover here, but can you simply differentiate between anxiety and depression with an anxiety component for the listeners?
Yes, it is and can be sometimes something which is difficult to tease out. What I would say is that if we look at, for example, generalised anxiety disorder, there'll be a presentation primarily of worry, people who can't stop or control their worrying, or have somatic symptoms such as heart palpitations, sweating, digestive discomfort, potentially panic attacks, issues with sleep, and just generally feeling keyed up or on edge and restless, muscle tightness, teeth grinding. They're generally our anxiety symptoms.
Yeah.
Depression, I've talked about that in terms of the mood aspects and some of the somatic and cognitive and psychological aspects. A lot of the time the issue is that they do co-occur. So you do get a common presentation of people who are depressed who do have some anxious symptomatology, and vice versa. If people have long-standing anxiety, there is statistically they're at a risk of developing into depression. So it's that case of sort of raised cortisol, impeding brain-derived neurotropic factor, and that actually impeding neurogenesis, and that may result in depression. So anxiety can certainly cause depression, doesn't always, and depression can present sometimes with some comorbid anxiety. And it's a case of using clinical judgment or getting a referral for a proper diagnosis.
So you've done a lot of work with, one of my favourite herbs, certainly kava. Tell me a little bit about the research that you've done with that and its application to use in anxiety.
Yeah, look, we've been very proud of our research at UQ and also at the University of Melbourne and Swinburne University of Technology. We've been doing a lot of work on looking at using kava, but a water-soluble extract of kava. There has been some issues in the past with it being withdrawn from the EU and UK and Canada because of concerns over liver toxicity. So the World Health Organization said, look, let's get away from these ethanol and acetone extracts. Let's go back to basics, and let's test water-soluble extracts using a rootstock of a noble cultivar, so I guess you'd say a therapeutic and recreationally used high-quality kava cultivar. So that's what we did. Our research is ongoing. We've already done a few clinical trials. They've been quite positive in terms of showing that kava, as we expect, would reduce anxiety. But we've also done work looking at pharmacogenomics. So we looked at a particular SNP, single nucleotide polymorphism relating to the GABA transporters, and the GABA transporters help with shuttling of the GABA in and out of the neuron. So, and we do know that kava has its effect mainly via GABAergic pathways. So what we've shown that in fact, yes, there are differences in people's GABA transporter polymorphisms depending on how they'll respond to kava. So, there's a chance potentially down the track, if we replicate this, that this could be a case of personalised medicine. We could go in, get a blood test and see, yep, you've got that particular polymorphism, without going into it, a particular allele for this particular SNP, and, you'll be a good candidate for kava. That's the sort of approach we're looking at. So we're doing an NHMRC study at the moment looking at using kava in generalised anxiety disorder, so proper long-standing anxiety. It's a large multi-centre study, and we hope to replicate the results of our last study, showing that kava was effective in generalised anxiety disorder. We're also hoping to replicate the results of showing that there are genetic differences in people who respond to kava, and we're also going to do some neuroimaging. So we're going to look at whether GABA metabolites change, the levels in the hippocampal amygdala region, as well as looking at some gene expression to see whether taking kava versus placebo triggers the manufactured expression of various neurochemical genes. So it's pretty exciting, and that work's starting up very shortly.
So if you're looking at GABAergic innovation, if you like, could there potentially be use for kava in, say, chronic pain?
Absolutely. Look, it can be. I'm not saying necessarily it's going to have a strong analgesic effect. I mean, potentially if it's used in high doses. Absolutely, having an anxiolytic effect is beneficial. A muscle relaxing effect is also beneficial. It can also have a topical anaesthetic effect. So certainly I see a place for kava in the treatment of chronic pain.
And have you ever seen any interactions with kava in, say, gabapentin? Its use with gabapentin?
I haven't personally, because obviously that's not the thing which you generally recommend. In fact, that would be, in some cases, a contraindication. A lot of the time when you do use the GABA agents, such as, for example, benzodiazepines, you would caution or contraindicate the use of another GABAergic agent, such as kava,
right.
Just in terms of, obviously having an overdose of that activity.
Right, so kind of like a gabatonin syndrome. That doesn't make any sense.
Potentially, yes. I mean, there has been some case reports of people, taking benzodiazepines and kava, for example, and turning up in hospitals, not being able to use their muscles very well.
Yeah.
And obviously there's issues probably primarily with, some movement disorders, but also, potentially respiratory, conditions. I mean, you want the person obviously to breathe.
Yeah.
That kind of helps.
So moving on to another commonly used, and to me it's a herb that seems to have lost a little bit of flavour, but it's a very useful herb, passion flower. And I was speaking to a practitioner just the other day who was using quite high doses for non-responsive sleep disorders. What's your experience with this in anxiety and other disorders?
Yeah, absolutely. Well, you had a nice, intro there where you just said people have lost their passion for passion flower. I mean, you missed a good opportunity there. Look, there has been some research done on passion flowers, obviously good traditional evidence, as an anxiolytic and as a sedative and a hypnotic. And look, it is a fantastic herb. There's no doubt about that. In terms of the dosage, I mean, I don't think that's been studied enough in terms of looking at those higher doses, because it's a fairly safe plant medicine, a very safe plant medicine. So there is a chance, if you do use it at higher doses, maybe it does have a dose-dependent effect, and you start to get more of a hypnotic activity at the higher doses. Absolutely. But we can certainly say, looking at some of the clinical trials which we have out there, that it does have an anxiolytic effect. It's also been shown to relieve preoperative anxiety and tends to be quite safe in terms of drug interactions, from what I understand.
Right. And moving on, again, another good old one, skullcap.
Good old skullcap. Yes, well, unfortunately, there's really only one clinical trial, a very poorly conducted clinical trial. I hope the gentleman who conducted it's not listening. Conducted quite a while ago. So really, I can't certainly say from an evidence-based perspective it's got the support. Once again, you have to rely on traditional evidence and clinicians' experience in terms of it being an anxiolytic. I've used it myself, clinically in the past. My sense is that it does have, quite a nice effect, but unfortunately, there isn't the robust research to support it.
Yeah, and did you use it alone or in tandem with other herbs like passion flower?
Oh, of course. I mean, whenever I think of anxiety treatments, I always think of, skullcap and passion flower going hand in hand. I don't know. They just, for me, intuitively tend to combine very well. And obviously with skullcap, you can use a lower amount. So if you're mixing herbs up, it's quite a nice addition to a mix. Doesn't really require too much, and synergistically, obviously, we don't know from an evidence-based perspective how that interacts with passion flower or some of the other anxiolytics you put in there, such as ziziphus, or some people may use withania. Chamomile's quite a good one. Maybe green oats, and I mean, there's actually one which I'd love to see a bit more research on. It's just we're looking at the moment with the World Cup in Brazil is Galphimia glauca, which is the golden shower flowers. There's some good research coming out of South America showing that's quite a potent and safe anxiolytic herb, so stay tuned on that one.
Mm-hmm. Great. And so have you got research upcoming on that, or you'd like to do research on that?
I'd like to do research on everything. It's just a matter of whether somebody gives you the money to do the research on something. So, look, I mean, it would be fantastic to do research on some of those novel plant medicines. I mean, the problem is that we love researching kava, and I should say that there's some fantastic news has come in, and that is that the regulatory authority in Germany, the court, has overturned the kava ban in Germany, which should have a flow-on effect to the EU. And it's just basically said, it's been, how do you say this? It was not recognised that kava should have been withdrawn from any liver issues. So I think we're going to see a resurgence in kava. I'd like to point that out, so that's quite exciting. But apart from that, we love researching kava, but we would absolutely love to research a range of plant medicines, because there's so many beneficial anxiolytic plant medicines out there, antidepressant plant medicines, but we just need to obviously do the clinical studies, so then we can say, hey, look, it's not just a matter of traditional evidence. This stuff really does work in a robust scientific model, and I think that certainly advances the profession much further.
I should point out to the listeners that one of the major reasons that kava was taken off the market in Australia was because of not just a kava product, it was a combination product, and it was found that combination product also had...
skullcap.
Skullcap, yes, thank you. It was a commonly adulterated herb, skullcap, which was adulterated with germander. And that was found in that particular product that caused liver problems in Australians, notwithstanding that there seemed to be issues with the acetone extracts overseas. Is that why it got taken off overseas?
Yeah, I mean, this is the thing. We've been doing a bit of research to try to tease out, are these liver toxicity issues actually occurring, or is it just been by chance that somebody has been found to be taking kava at the same time as they've been drinking fairly heavily, or they've been taking all this other medication, or they had a pre-existing liver condition. Looking at the results, there's only a handful of cases where causality is probable in respect to kava, so we cannot say that it is not a phenomenally rare occurrence. Some of the data have shown it could be sort of 2 cases in millions of uses of it. So, in terms of why it's happening, we're teasing that out. In fact, we're actually doing a preclinical study at the moment looking at hepatocytes stabilised in matrigel. So we're creating sort of, I guess you'd say, sort of representative models of the liver, and we're testing various kava cultivars, various kava plant parts, and for example, the skins of, say, the 2-day kava, which is generally not used in medicinal practice, versus the roots of the noble cultivar, which is what everybody's drinking. So we're trying to tease out, because the problem is that we don't necessarily think that, yes, kava per se has any liver issues. It could be potentially the type of cultivar used. It could be the type of plant part used, for example, the skins, which were bought up quite readily because they're very cheap back in the late 90s and early 2000s. Could it also be, for example, that, yes, the ethanol and the acetone has had some effect on drawing out some of the chemicals you don't want. So we're doing these studies to try to find out, really what's going on with that. Yeah. And hopefully, we will have some results on that in the near future.
So just going back to, our first topic on depression, it's got a very high medication failure, certainly for first try. Is this a case of sort of, guess which neurotransmitter is dysfunctional, and so we try the next type of medicine which works on a slightly different neurotransmitter? Are we at the stage yet where we can confidently either test for which neurotransmitter is out of balance, or is there any other way that we can more effectively target the therapy?
Yeah, that's a very good question. And the reality is that I think what you're talking about there is personalised medicine. And I think we are at the doorstep of the age of personalised medicine. And that's why, for example, with the studies we do of looking at genetic polymorphisms, that is one way of trying to determine, whether a person will benefit more from one medication or the other. In terms of sort of working out which neurochemical pathways are dysfunctional and thereby tailoring medication, there has been some work on that, and I've got colleagues who are doing some research on that as well to try to determine, for example, with neuroimaging, to see whether there are certain pathways which are dysregulated, and based on the neuroimaging results, also potentially the saliva biomarker results on tailoring medication according to that. Who knows? Look, it is a very complex condition when you look at major depressive disorder and a lot of the psychiatric disorders, because you have a brain which is neuroplastic, and one presentation one day, and this is the big issue, this is my bugbear with it, is that, yes, somebody comes in with major depressive disorder, they'll present in a certain way, okay, you give them medication based on that, but it's labile, so 2 weeks down the track, maybe it presents more as in an anxious presentation, or they start to have sleep issues, so the issue is that things are constantly changing. Yeah. So it's trying to have medication and treatment protocols which adapt to that. So I don't think it's a case of necessarily one size fits all regarding giving a certain antidepressant. And yeah, you're right. It would be fantastic to tailor people's treatment depending on what is actually happening biologically. I mean, for example, some antidepressant agents work more on serotonergic pathways. Some will have additional effects on noradrenergic. So I think clinicians are aware of that, and they are, to some degree, having some flexibility on presentation, but we are really at the tip of the iceberg, and it really has to be, I think, a lot more personalised as we go forward in the future.
And I think you made a very important point as well with regards to not just personalised medication on a population level, but on a patient level. And this is something that I'm really strong and keyed into, that we must retain the treatment of the patient at that point in time. And with, I get that medications, the pharmacological agents must work on a population level, that sort of level. But I think the beauty of natural medicine is that we can change our formula as to the presentation, that visit, yes, and what's going on at that point in time. And I think that's where the beauty of natural medicine lies.
So I couldn't agree more. That is one of the fundamental strengths of seeing a natural medicine practitioner, and when they're prescribing their herbal medicines, they're prescribing their nutraceutical supplements, as well as tailoring lifestyle advice, is that this is fluidic and this is personalised, and that individualised approach, I think, is incredibly beneficial, rather than turning up at the doctor's office and here's your script, mate, and we'll see you some way down the track. We're obviously, I understand that doctors are under a lot of time pressure, but regardless, I think what patients want in a lot of the time is to have that personalised individual care.
So let me move on from that, because that lifestyle point is a very important point, and the role of cognitive behaviour therapy, or CBT, or other people sort of liken it to mindfulness. It's gaining notoriety in a lot of conditions, and certainly versus a comparator of a pharmacological agent. What are your thoughts on this, and how do you use it in practice?
Oh, look, it is an evolving area, and I'm just personally very pleased it is. I meditate myself, love doing mindfulness work. I'm certainly not very good at it, but at least I try. And, I think what's great about it is that, they've drawn from a lot of the time these traditional Eastern practices, Buddhist, yogic practices, and synthesized it and applied it for, the Western person. So it's psychologically palatable. But at the end of the day, it's going back to those traditions and just keeping it simple. And in terms of mindfulness, there's great evidence showing that mindfulness meditation, or the mindfulness application in cognitive behavioural therapy, is quite effective in improving mood and reducing anxiety. So absolutely, that's something which people can do mindfulness meditation or mindfulness-based stress reduction courses, or they may be able to see a psychologist for referral and actually be taught sort of more of a CBT-based mindfulness. But yeah, absolutely. Very, very robust evidence starting to emerge for the use of that technique, so fully encouraged.
One thing that makes me a little bit uncomfortable with a diagnosis of a psychiatric illness or a psychological condition is that we get keyed into that is it, rather than what came before, what caused it. something normally causes these things to happen. Do you have any hints and tips for practitioners to try and tease out what is the root cause and how to support that?
Well, I don't know if I can relieve your discomfort, Andrew. Unfortunately, look, and I've never seen you not comfortable, so it concerns me. But look, seriously, this is a really complex area, because when it comes to mental health, usually the causations of a particular mental illness are multifactorial. You've got genetic interfaces with psychosocial determinants. I think you can wrap into that, which really isn't explored enough, the effects of just basic lifestyle in terms of, what's happening with their nutrition. It's going to have effects on their neurochemical production and transmission. Are they exercising? What's happening cognitively? What's their cognitive schema like? So it rarely comes down to one particular silver bullet. Okay, that's what started the pathogenesis of that person's depressive disorder, for example. It really is quite interrelated and complex, and that's why, for example, it is quite a simple approach saying, look, you take an antidepressant, because at the end of the day, at least, you can get things firing neurochemically back to balance, and if that's the case, yeah, that's great, but you have to obviously encourage the person to do the psychological work, which hopefully addresses the underlying issue, because all the time it is a psychological aspect. But also equally, it can also be a poor diet and a sedentary lifestyle, which can also be involved in the pathogenesis. So it really comes back to, I think, as always, an integrative approach.
Okay, so talking about integrative approaches for depression and anxiety, what other things can practitioners do? What sort of advice can you give them?
Yeah, that's a great question, Andrew. Look, there are lots of things which clinicians can do, and this is why it goes back to, it's not just all about medication or all about supplements. Really that is just one aspect, one element in terms of promoting good mental health and treating mental illness. I think that we have to really encourage the exploration of improving a person's diet. There's good evidence showing that high-quality diets and whole foods, low-processed foods, will have an effect on improving mental health, reducing depression and improving anxiety levels, as well as exercise. So getting people off the couch, encouraging them gently at their own pace, because you don't want to push them too hard, with getting out there and doing some form of exercise. It tends to also, the evidence show that it's dose dependent. So if a person does a little higher intensity exercise, it has a stronger mood elevating effect. But also encouraging them to engage in some psychological therapy. So that might be CBT, for example. It might be some sort of interpersonal and narrative-based work with a counsellor. That can be very beneficial. As well as looking at other aspects such as sleep. There is strong evidence showing that poor quality sleep does very much impact mood and can, certainly have an increased risk, sort of 2 to 3-fold, with a person developing a depressive disorder. Looking at substance misuse, so there can be issues of people with psychological disorders relying on alcohol or cigarettes or recreational drugs in order to adjust and to work with their level of mental distress or illness. So a matter of sort of getting on top of some of those issues as well. Alcohol use, unfortunately, can tend to be very highly abused in people who do have depression and anxiety. So there's a range of issues, and just little things. I mean, one thing which I'm quite interested in is, what about green space? Exposure to nature. Exercising in nature is shown to have an even stronger mood and self-esteem promoting effect. So those sort of aspects, exposure to sunshine, pet therapy, the effect of animals and the beauty with that, our effect with relationships and the cultivation of compassion and love, altruism, giving, having that particular mindset. I think all of these aspects can be cultivated within a therapeutic relationship if there's enough time to do so, and if there's enough will on both sides of the therapeutic fence. People can transform their lives So it's not just a magic bullet with taking a supplement. It's really having that integrative approach and promoting, really good mental health.
Couldn't have put it better. It's absolutely brilliant advice, Jerome. Thank you so much. We're going to have to leave it there, but I really cannot thank you enough for not just the clinical advice, but the practical advice that you've given the listeners today, because it will really help both them and their patients. Indeed, I would say it will help many clinicians look after themselves better.
You're very welcome. Thanks, Andrew.
This is FX Radio, and I'm Andrew Whitfield Cook.